Good evening, friends. It is a proud and happy moment for us to be with all of you this evening for yet another edition of this IAGES Prime Time. And I take pleasure in hosting a very important faculty for this evening. We have none other than the legendary bariatric surgeon of this globe, Professor Fobi, joining us this evening. And he is again hosted by one of his very early career students, Dr. Jaydeep Pale. And I also should share today's evening is exclusively with Dr. Fobi. And I also should share the information that Professor Nundy could not join us because of a recent positive viral infection status. He's at present stable. So, ladies and gentlemen, let us get into the program per se. And I'm happy to introduce my good friend, Dr. Jaydeep Pale. Dr. Jaydeep Pale is right now the head and the director of the bariatric surgery at Nanavati Super Speciality Hospital. And he's been practicing bariatric surgery and foregut surgery since 2001. And he's been instrumental in setting up the Department of Bariatric and Minimal Access Surgery at Nanavati Hospital. Dr. Jaydeep Pale has a very distinguished career and a distinguished academic tenure. He has completed his bachelor's degree from GS Medical College, KM Hospital, and master's from the Topiwala National Medical College. And he has been a teaching faculty at LTMMC and Sion Hospital, Grand Medical College, and Sir JJ Group of Hospitals, and has accumulated teaching experience of more than 10 years. And he's also instrumental in setting up the bariatric surgery program in Kokilaben Dhirubhai Ambani Hospital, starting December 2012. And he is now moved to Nanavati Super Speciality Hospital as the director and head of the Department of Bariatric and Minimal Access Surgery. And Dr. Pale has have the fortune of getting trained by the pioneers, and more so, he's been a direct student of Professor Dr. Fobi. And he also has a special interest in robotic GA surgery. And he got trained as early as 2006 and moved on to various robotic surgeries from the early part of Da Vinci's installations. With that few words, I'm happy to hand over the day's proceedings to Dr. Jaydeep Pale. Dr. Jaydeep, please.
Very good evening, everyone. We are very happy today to welcome, as Dr. Kanagwal said, Professor Mathias A.L. Fobi, more popularly known to all of us as Professor Fobi. And this is IAGES Prime Time, and we are going to see and discuss and talk with Professor Fobi today and find out why he is such a big legend and pioneer in the world of bariatric surgery, the world that we know, not only in India, but all across the world. To begin with, let me firstly welcome you, Professor Fobi. Very good evening to you. Good morning to you out there, since you're in the US. And Professor Fobi, as all of us know presently, is the Director of Clinical Affairs and Research at the Mohawk Bariatrics and Robotic Center at Indore. And he's also the Clinical Professor of Surgery at the Sri Aurobindo Medical College and Postgraduate Institute in Indore. He has had the proud privilege of being past president of the ASMBS of the IFSO and is the chairman of the board of trustees of IFSO. Apart from being an innovator, surgeon, clinician, and teacher and mentor for so many surgeons across the globe, Professor Fobi is also known for his philanthropy and for his work that he has done, not just in the United States, but also in his country of origin, Cameroon in West Africa. I had the proud privilege, as Dr. Kanagwal said, to visit Professor Fobi way back in 2011 and 12 when I was with him and spent 2 weeks at the Tri-City Hospital and the CTSO. And from there on, we went from strength to strength in our relation and our bonding. And I've also had the privilege of hosting him in Mumbai at the Kokilaben Dhirubhai Ambani Hospital, where he gave us a very good lecture. And I'm so happy today to have Professor Fobi here with us today and enlighten all of us and show us how he has found his way over so many decades, right from his birth in Cameroon till now at Indore. Professor Fobi, without wasting any further time, I will hand over the session to you. We would first like to hear from you about the banded gastric bypass of the Fobi pouch, and there on after that we will go from strength to strength. Over to you, Dr. Fobi.
Thank you. Let me share my screen with you.
Yeah. Sorry. Let me just.
Okay. Thank you, Jalip, for that kind introduction. Thanks to Dr. Goel, who has invited me to be part of this series. I'm very honored that you consider me one of those that is deserving to participate in this series. And I hope I'll contribute to the importance of the series. As you've been introduced already, currently I'm in the US, but for the last 4 years, I have been in India working with Mohit Bandari and his team at Mohawk. So I bring you greetings from Mohawk and the same university, and you see the laser center there on the left upper hand corner. That is where we do most of the research work and robotic and endoscopic teaching. For my disclosure, I am currently and still the founding president of Bariatric Corporation that makes rings for bariatric procedures. I personally had a banded gastric bypass to treat my diabetes. I had that 9 years ago, and I have had complete resolution of the diabetes, and I lost a little bit of weight, which I've maintained for the last 9 years. My case mix, if so recommends, I will put our case mix so people have an idea of what we do. Currently, I do about 1/3 banded gastric bypass, 1/3 banded sleeves, and 1/3 anastomosis gastric bypass. The evolution of gastric bypass to the banded gastric bypass, which I'm going to talk about today, has been characterized by many operations that were improvised, popularized, and abandoned when they did not meet the test of time. The evolution has been characterized by looking for effectiveness in terms of weight loss and weight loss maintenance, and also trying to establish safety. You have to look at the risk-benefit ratio of any operation. In that case, keeping morbidity less than 10% and mortality less than 1%. Usually at this time, we talk about less than 0.1%. So the gastric bypass has evolved over time from 1967 when Mason published his first series to 1992 when I popularized the Fobi pouch procedure called the banded gastric bypass. And this has been characterized by us making changes. Banding the pouch in gastric operation is not new. In 1980 and 1981, Mason and Laws described the vertical banded gastroplasty and the silastic ring gastroplasty. It was John Lehner who applied the principle of banding the gastroplasty to the gastric bypass by placing a ring around the anastomosis. Unfortunately, the location of the ring results in a lot of ring erosion. This is one time when I'll tell you, when you go to a meeting and find something, don't go home and practice it. Dr. Lehner came to my symposium in Los Angeles and presented this, which I thought was a great idea. And I started placing the ring, and I did 40 of them, only to find out that they were eroding. And when I called him, he says, yes, Mal, those rings erode. Please don't do them. So sometimes when you get a presentation at a meeting, take time to look at it and see how long it lasts before you adapt it. But that inspired me, and I looked at the work of Dr. Salmon, and from then on, we went on to revise gastroplastics to gastric bypass. And in a series of cases, we were not able to take off the ring or the band. So we did the gastroenterostomy below the band. And this is something which is relevant, which I'm going to occasionally go to, is the idea of making sure you collect your data. Because of the volume of work I did, Dr. Mason invited me back when I started in the 70s to join what was called at that time the Bariatric National Registry. So every surgery we did, primary or secondary, was entered into that registry. So when I had a chance to present at the ASBS meeting, or at that time, which was called the Bariatric Colloquium in Iowa in 1980, as a matter of fact, it was more like 7 to 9, we started looking at some findings that were interesting. We saw that patients who had had a gastric bypass with the gastroenterostomy below the band did much better than those who had a regular gastric bypass. And since I was entering all my data into the registry, we were able to extract the data and do analysis looking at gastroplasty, gastric bypass, and the gastric bypass that had been converted with the band in place. And it became apparent that those who had had a gastric bypass with the band in place, the yellow triangular markings, as you can see from this projection, did better than the regular gastric bypass and did better than the gastroplasty operation. So because of that, we then thought, why not do a banded gastric bypass primarily? And then we started doing that in 1989. And I published the first series in the Journal of Obesity and Weight Regulation. I'll let you know that at that time, when we submitted publications to the American Journal of Surgery, SGNO, we were not well respected. Obesity surgery was not accepted. So we were submitting most of our work into what was called secondary publications. With time, we had a problem with the surgery because we were having a lot of staple line disruptions. So we transected the stomach. In order to make sure that we didn't have leaks, I used a small bowel to placate the cut edge of the pouch, which minimized the incidence of staple line disruption. And this is the operation that was then called the Fobi pouch operation. Now, I did not call this operation the Fobi pouch. The story is this. When I started doing the gastric bypass, most of the hospitals did not want me to do the operation because they heard the word bypass and everybody thought about the intestinal bypass. So for me to get privileges, I had to describe the gastric bypass as a limiting proximal gastric pouch with a Roux-en-Y gastroenterostomy. So when patients came to have surgery, they came to have the pouch with a Roux-en-Y gastroenterostomy. That way, I was able to get privileges to do the operation at hospitals. And when I finally described the banded gastric bypass, everybody called it the banded pouch. And then with time, people called it the Fobi pouch. But basically, it's a gastric bypass with a ring placed 3 to 4 centimeters from the gastroesophageal junction. This is material we extracted from the registry when we looked at what I had done. And we went from 97 cases in 1992 to 492 banded gastric bypass procedures in 2002. When we extracted the data from the registry, as you can see here, you can look at this as each one of them as a different series. We looked at patients that were done in 92, patients that were done in 93, patients that were done back to patients that were done in 1990. And if you look at it, no matter when the cases were done, the weight loss at 2, 3, 4, and 5 years later were about the same. The patients all peaked at about 2 to 3 years, and after that, the weight was maintained. There was minimal weight regain. That is what encouraged me and allowed members of the American Society of Bariatric Surgery to accept it because the data was objective and it was coming from the registry. And you could not argue against objective data. But what was more impressive is that when we analyzed this data, and you can look at it here, let me minimize this part here. When you talk about, or when most people report data, they talk about the average percentage excess weight loss. When you look at the non-banded and the banded procedure, In the beginning, 67 and 77 in 2 years is not much difference and not significant. Then in about 6 years on, you start seeing a difference. But again, 58 and 69 is not that significant. But if you analyze the data and look at it in terms of success rate, which meant how many of those patients maintain an excess weight, 50% excess weight, then you find out that only 66% of those who did not have a band maintain an excess weight above 50% excess weight, whereas 92% of those who had a band maintain an excess weight above 50%. This is very important. So when you look at average weights, they don't tell you much. And you may say both operations are equivalent. But when you look at the procedures in terms of how many are successful and how many have failed, you find out that banding the gastric bypass decreases the non-response rate to less than 10%, which is very significant. My work was collaborated by publications by Howard from Albany University, who incidentally, unknowingly to me, has started doing a banded gastric bypass in 1986. He compared a banded gastric bypass to a banded gastroplasty. And as you can see, he also showed that the weight loss after the banded gastric bypass was maintained at about 77% up to 7 and 8 years after the surgery. Very similar to my findings. Many doctors attended my symposium in Los Angeles, which I had every year starting from 1981. And they went back and started doing the banded gastric bypass in different parts of the world, in Spain, New Zealand, Venezuela, Brazil, Chile, Mexico, and also in India. This is a study by Dr. Howard from Chile, where he shows that the banded gastric bypass at 12 years maintains the weight loss, whereas the non-banded gastric bypass starts gaining weight after 24 months and results in a failure rate of about 20 to 35%. There have been prospective comparative studies. Bresler did one where he showed that in the super obese patient, if you look down here at 38 months, there was a difference of 73% excess weight loss versus 57, comparing the banded versus the non-banded gastric bypass. So particularly in patients who are super obese, the banded gastric bypass does a better job maintaining the weight loss. Many doctors have placed bands in patients who have failed, and they've documented that the bands cause increased weight loss after the gastric bypass. Mason in 1994, looking at my work, said it was obvious what I had shown because the Roux-en-Y gastric bypass is primarily a restrictive procedure, just like the vertical banded gastroplasty. So it is important that the outlet to the pouch does not stretch. Similarly, Dr. McLean, one of the renowned surgeons in the American College of Surgeons, reviewed the work by Capella, who was doing the banded gastric bypass after visiting with me, and said this was about the best bypass procedure because it had excellent weight loss maintenance. Fisher did the first systematic review and concluded that placing the ring around the pouch increased the weight loss and increased the weight loss maintenance for a long time. In 2006, another systematic review was done by Dr. O'Brien, and he showed that the banded gastric bypass was superior to the standard gastric bypass and to the distal Roux-en-Y gastric bypass, looking at the time from 6 to 10 years after surgery. Philippe, in the textbook of Handbook of Surgery that is published by Dietel, reported that the banded gastric bypass produces results, if not better, at least equivalent to the BPD and the duodenal switch, without the associated metabolic consequences and complications. He talked about a 1 to 7% band-related complications, and most of them could be treated appropriately. Now, what have we learned from this? We learned that dilatation of the pouch is the natural history for any gastric procedure. So it is not that you do anything wrong. When you do a gastric procedure with time, the stoma dilates and the pouch, the stoma, and the proximal jejunum becomes a single entity, and that allows the patient to eat. Further studies have been done to show that with time, when the stoma increases, you can correlate the size of the stoma and the increase in the pouch and the reservoir with the weight regain. So you can see here, as the diameter of the pouch increases and the size of the pouch increases, the weight gain is increased. This was published in the Clinical Gastroenterology and Hepatology Journal. Gagne stopped doing gastric bypass when he documented that the gastric bypass ends up with a dilated stoma, a proximal jejunal dilatation with a large stoma. And that is when he stopped doing the gastric bypass and then went to do the duodenal switch. And you know what happens after that. Now, if you look at this X-ray here, this is a dilated pouch from one of my patients. This pouch is dilated. This is supposed to be the gastroenterostomy. You see it's dilated. The proximal jejunum is dilated. This patient has a stomach now where the patient can eat a whole hamburger, have some French fries, and drink a whole Coke. That way, the patient is defeating the surgery, and that's why you have about a 25 to 60% weight regain after the gastric bypass in some patients because of the pouch dilatation. This is a picture that you've probably seen. This was given to me by Dr. Luke Lemons, where he showed the jejunum dilating to about 12 to 15 centimeters. So the jejunum becomes a reservoir. Patients eat into that reservoir, and they can eat large quantities of food. Now, if you put a ring around this pouch, it takes away the ability for the pouch to dilate. And so the patient has a fixed stoma. It's not restrictive, but it's wide open. If you do an endoscopy, and we do them on surveillance endoscopy, you can see that stoma open. And on this X-ray, you can see the pouch, proximal pouch, and the overlapping jejunum, which are used for plicating, and that is the pouch right there. Dr. Katz has done contrast studies to show the effects of the band. Without the band, as you see, the proximal pouch and the proximal jejunum dilates, and the patient, the volume goes to up to 290 to 305 milliliters from 30 centimeters. When you put a ring there, that proximal pouch never gets anything beyond 40 to 45 milliliters. So this is a diagram to show you what happens when you have a non-banded pouch versus a banded pouch. The non-banded pouch has a natural history of stretching. You can't blame the patient. That is normal. Some patients who eat as instructed would have a dilated pouch, but they will not have weight regain. But most patients eat as long as the stomach would allow them to put it in, and therefore a good number of them end up regaining weight. We have since found out that the mechanisms for bariatric surgery are multifold. Banning the pouch in the gastric bypass enhances three of those mechanisms: the restrictive effect mechanism, the neurostimulation of the gastroesophageal junction, which is called the full sense effect. When the pouch feels full, it distends the esophageal junction, and the brain is told that the patient is full. And the force compliance. When you have a gastric bypass, the patient has to chew the food, take small bites, and eat slowly. After a while, when the pouch stretches, the patient can just eat without doing that. When you put a ring there, the patient is forced to eat at 2 years, 3 years, 4 years, as they were eating 6 months after the surgery. That means they are forced to take small bites, chew their food thoroughly, eat slowly, and therefore they cannot eat so much because they get a full sense of satiation, and that is why the weight loss maintenance is there. I know it because I personally can only eat so much with the ring in place when I had the banded gastric bypass. The other principle that we have learned over the years is that we don't have to make the ring restrictive. The ring has to be loose, and it should be at least 2 centimeters above the gastroenterostomy. So initially, for the first 6 months, the patient who has a band cannot tell the difference between the one who has a band and the one that doesn't. It is when that pouch starts stretching, that band limits the stretching, and therefore makes the patient maintain weight loss. So banning the pouch enhances the weight loss and weight loss maintenance after the gastric bypass. It is good in the obese, the super obese, the super obese. It's good in young, old age, and other patients. The principles of banning the pouch has been so good that it has been extrapolated to banning the mini gastric bypass in this era where we're decreasing the biliopancreatic limb. And here Clark has reported a 10-year series with a banded single anastomosis gastric bypass, or what we call banded mini gastric bypass. Banning the pouch has also been extended to the sleeve. You see the sleeve, dilatation of the sleeve is the Achilles heel in the sleeve operation. About 40% of the sleeves are going to fail because of the pouch dilating. We now have studies. We have a 6-year study at Mohawk, which shows that the pouch is controlled in the sleeve. The weight loss maintenance is maintained more than 6 years after the surgery. And in this report here, you see Dr. Fink is reporting a 5 years follow-up showing that in the non-banded sleeve, they regain weight, whereas in the banded sleeve, the weight is maintained at about 37% total weight loss. Various materials have been used to band the sleeve. The GAB ring, IOC ring, lab band, and minimizer are prefabricated standardized devices that are in the market that can be used for banding the pouch in the gastric bypass, the one anastomosis gastric bypass, and the sleeve. The one advantage of banding the pouch in the gastric bypass is you don't have to make a gastroenterostomy as narrow as recommended by most people in the field of bariatric surgery. You can make the gastroenterostomy as wide as 2.5 centimeters because the ring is going to be what limits the flow in the long run. And therefore, by making a large gastroenterostomy, the incidence of stenosis requiring dilatation is minimized after the banded gastroplasty. Whereas in the non-banded operation, that incidence runs from 6 to 23%. Also, we find out that banding the pouch has minimized the incidence of reactive hypoglycemia, and Dr. Stefan in Switzerland and his colleagues have published series where they have treated patients with reactive hypoglycemia by placing a band around the pouch, and we have documented in our own series at the Center for Surgical Treatment of Obesity that only patients who had their band removed had reactive hypoglycemia, whereas patients with a band in place very rarely develop that syndrome. There are complications from putting in the band. The most common one is food intolerance. That is a desirable complication. Very rarely do you have to do anything but dietary counseling because of the food intolerance. The food intolerance is due to non-compliance by the patients. The patients who eat fast, take large baths, don't chew their food well, are going to have intolerance. When they follow the instructions as they should, that problem is resolved by nutritional counseling. Occasionally, a patient finds it so bothersome that the band has to be removed. The other complication which is inherent in putting a prosthetic device is erosion, and there's about a 2% incidence of erosion, and that is best treated by endoscopic removal. The other problem that is treated by laparoscopic intervention is slippage of the ring if the doctor does not anchor the ring to the pouch as he or she should. In that case of band erosion, you can see here the band erodes. If you leave it alone, it was extruded into the gastrointestinal tract and be passed out. Otherwise, you can go in with an endoscope and cut the ring and remove it, and then dilate the stoma, and the patient would be converted to a standard gastric bypass. And you very rarely need to intervene surgically. In patients who have a band and they're having problems eating, you don't even have to intervene surgically. You just go in and put it in a stent. That will cause that band to migrate, and then you can take it out endoscopically. So that's the beauty about doing banded procedures. They have a complication of food intolerance. If the patient is so intolerant, you don't have to do a laparoscopic procedure to take out the ring. You can induce erosion by dilating the stoma over and over, or you can put a stent. So banding the sleeve increases weight loss maintenance, and is very effective. As the obesity epidemic persists and more patients undergo surgical intervention, there will be more and more patients at risk of inadequate weight loss and weight regain. The reservoir size has been documented to be a risk factor for inadequate weight loss and weight loss regain, and therefore putting a ring around the pouch to control the reservoir size is a good adjunct to gastric operations for obesity. These are patients 10 years after their operation, maintaining their weight. We did this in a 15-year-old, and you can see 10 years later, they're doing fine. We did this in movie stars who barely had the surgery at a BMI of 33 in the United States. We did this in super obese patients, and you can see they come down to almost a normal weight. And these are two of my patients who had 10-year follow-up, and they were both maintaining their weight loss. I want to thank the staff at Mohawk who worked with me and helped me prepare these presentations. And I'll answer any questions Dr. Pelly might have, and I hope you have a better understanding as to the essence of the banded procedure. Thank you.
Thank you, Professor Fobi. You gave a very clear presentation of what you have learned over 4 or 5 decades. Now, I'm happy to invite Dr. Raman Goel, the President of the Indian Association of Gastrointestinal and Endoscopic Surgeons, to formally welcome Professor Fobi. And I'm sure Dr. Raman was also one of the early students of Dr. Fobi in learning bariatric surgery almost 15 years ago. Dr. Raman, your thoughts and comments, please.
Good evening, Dr. Fobi. Welcome to IAGES platform after a long time. It's always a pleasure to listen to you because you have been a part of bariatric development right from beginning. At the time when bariatric was almost like illegal activity in USA, where you would meet in places so that the media doesn't get to know that you are holding a meeting of bariatric surgeons. From that to this level, when there is a worldwide recognition of bariatric, especially in India, I think you have been a pioneer, a legend in this area, and it's a real honor to know you. I remember somewhere in 2003, you visited Mumbai, 2003 or 2004, and we hosted you in Bombay Hospital. And I remember when I went to meet the hospital administration to invite you, we put out the posters that meet the creator himself, because the man who started the Fobi pouch. And that acquaintance grew that in 2004, I visited your center, and you had been gracious enough to invite me to your home and hosted a dinner in your large house and in the lawns with the staff of your hospital. And it was an amazing learning experience because, as I always say, this was a turning point in my life, because I realized how a surgery's outcome can be improved by small changes that a surgeon can bring to make the surgery safer and more acceptable. By making the surgery, by plicating a bowel over the staple line, or by putting a band, or by doing a gastrostomy ring, so that in future, if ERCP is required, the scope can be put directly into the stomach through that ring. So I think it's not only the steps, but the philosophy behind it. What you shared was that you can make the surgery safe, and you can make patient comfortable in terms of outcomes. So I think within 6 months of coming back from there, I brought few rings from you, because that is the time when Bariatric Corporation was launched. I was in the launch party of that. I brought few rings, and I did the first ring in 2004 and in India. So I think it's a great pleasure to know you, know your wife, Helen, and daughters, and to know that you subsequently underwent a surgery yourself and have been able to maintain weight. I have been hosted by Dr. Fobi in different parts of the world. He hosted me dinner in Sydney, in New York, in Porto. So the list can go endless, and it's a great honor to know him, because he's a man who has walked the talk. He has been able to emphasize that data keeping is so important and published his results. And I think Indian bariatric surgeons, and not only bariatric surgeons, by what we have learned from him, we are trying to replicate that in general surgery also now. Owe a lot to him, because when he shifted to India to be a part of Mohit's team in Indore, and even before that, in every meeting, he would emphasize that you should present your data and let that data speak, And over a period of years, most of the surgeons, bariatric surgeons, which include Jaideep and all of us, have started publishing our data. So if you see what happened before Dr. Fobi came to India and after he came to India, there's a marked difference in the publication numbers, and people may not acknowledge it, but I openly accept that this is the influence of Dr. Fobi's movement from USA to India. And now, as the president of this association, I am very clear that the research is the way. So IAGES this year has formed a research committee, and we are pleased to start 3 research projects under IAGES on gallbladder, appendix, and also COVID-recovered surgeries. So I think these influences go beyond personal relationships, because the word spreads, and if you want to use that, it comes very handy. The knowledge comes handy. So I'm happy that Dr. Fobi could spare time to join us today and be a part of this program. I see that probably he's logged out, but I'm sure he'll be joining soon. And before we go on, I can go on about Dr. Fobi endlessly, because we had words and words of talks for hours together in various meetings on how to take bariatric surgery forward in India, words of wisdom from him. So I think Dr. Jaideep Palip is waiting, and there is a video that we wanted to show about Dr. Fobi. So thank you very much, Dr. Kanagvel, for inviting me to this program. And it's an honor for me to be a part of a screen where Dr. Fobi is also there. So thank you so much. Please go ahead with your program and the question-answer session after that.
Thank you, Dr. Raman, for allowing us to host Professor Fobi this evening. Now I hand over the evening's proceeding to Dr. Jaideep, that can play the video and go through the question session. I hope Dr. Fobi is able to join back by then.
Thank you, Dr. Kanagvel. Thank you, President Sir Dr. Goel. I will just play, for the benefit of the audience, this particular video, which gives us a snippet of about the life of Dr. Fobi. And my partner in practice, Dr. Nidhi, was kind enough to quickly help edit this whole thing. It was a long video, an old video about Dr. Mal Fobi and his life.
Want the fat person to feel accepted in society. I am
born in West Africa. I went to a Catholic primary school. Most of the schools were missionary schools. They were boarding schools, very rigorous. The days active. My training in pharmacy was chosen mainly because in the United States there was not a program where you can go into medicine directly. I had always wanted to do medicine. Well, when I went into medical school, I was planning to do general surgery, mainly because I was still planning to go back to Africa and practice. And when you practice in Africa and you're at a hospital, you do everything, and the best qualified person would then be a general surgeon.
Oh my God.
My involvement in bariatric was really serendipity.
Can you log in from your
in
phone?
My designation as a nutritional support person, I was given a patient to take care of who came in with complications from GI bypass surgery. My interaction with this patient opened my eyes as to the situation with the morbidly obese. And through the assistance of Dr. Alexander and a supporting role by Dr. Mason, who sent us the necessary information, we were able to convert this patient from a jejunal bypass to a gastric bypass. It was interesting because this was a time when there was a moratorium on bariatric surgery in the Los Angeles area. And at that time, I was one of the only surgeons, probably on the West Coast, that did any bariatric surgery. So I had referrals from all the academic centers. I had the first publication, the Bariatric Surgery Newsletter, that was published first in 1982 and was published through 1987. And this was the only publication on bariatric surgery at that time. If you look at one of my editorials in Bariatric Surgery newsletter in 1983, I did say that bariatric surgery could be used for treating diabetes. And today that has become well accepted. My meeting and Dr. Mason's meetings in Iowa were the only two bariatric meetings in the United States until the formation of the American Society of Bariatric Surgery.
Teaching others to fish has always been Dr. Fobi's philosophy. He and his wife, Helen, fund the Bobby and Weberford Foundation, which provides scholarships to students who, without financial support, cannot obtain post-secondary education. To date, more than 150 students have benefited from these scholarships.
All right. So we are back live. That was a small video which showed us the life of Professor Fobi, right from the time that he was born in Cameroon in West Africa, a very small country, formerly a French colony, and then eventually how he moved to the United States of America, and how he climbed up the ladder doing pharmacy for his bachelor's, and then joining a school of medicine, doing his graduation, then doing his residency in Los Angeles, and from there on, we all know the rise and growth of Professor Fobi into the world of bariatric surgery. Now, unfortunately, Professor Fobi's electricity is down back in Georgia, where he is located, and he's trying to rejoin the meeting in the meantime. But as
Dr. Jaideep, I would like to step in at this point after until Dr. Fobi comes.
Yep.
Having you both worked in Fobi, I think I will take this opportunity to listen from you. What have been your experiences? And first, let me ask Dr. Raman. Sir, you should have been inspired into bariatric surgery at a very early part of your career. Like, what was your experience moment you saw Fobi working on this bariatric work, and how was the reception to you in his unit, Dr. Raman, please?
So I was there in somewhere in 2004, and I had already started doing bypasses, but we wanted to show some center which is doing large volumes. And in his unit, there would be 4 surgeries a day. So he will operate 2 cases in a day, and Dr. Lee, who was operating in the parallel OT, would operate 2 cases. And both surgeries, they will take somewhere about 2.5 to 3 hours each. And they were never in a great hurry to finish up, because they never scheduled a 3rd surgery or 4th surgery, though they had a waiting list. So I think understanding this, that each patient is important, in each surgery is important, and each life is important, is so important for a surgeon from India, where you are told to finish up a surgery fast in 40 minutes, 60 minutes, because the anesthetist is in a hurry. And there's a system that you start at 9 o'clock, 12 o'clock you finish, you have your lunch, you have your round, then you have another surgery at 2 o'clock, 5 o'clock you finish, you see your patients who are coming for admissions for next day's surgery. So I think there was a system which is not very, very difficult to implement even in a nursing home. And I learned that art of working in a system in a hospital, which coming from a small town of Mathura, I always thought that these are very big issues which cannot be replicated. But working there, I realized that these are very simple issues. You need to set your priorities right. And the nurses and everybody were so well trained, as we all know that nurses are so well trained in US. But so I think, and then there was a lot of personal issues. Like for first 4 days, every evening he took us out for a dinner with his family, or the hospital team, or the corporation team, which doesn't happen in India. You know, we seem to be so preoccupied that those who are visiting us are never given that respect that they deserve. So I think I learned a lot more from Dr. Fobi beyond surgery, the art of interacting with people, art of hosting people, and that has come quite handy with me. So I think Dr. Fobi has joined. I can see him in his car.
His car. Good evening, Professor. Good morning, Professor Fobi. I think he's getting connected. Good morning, Professor Fobi. Welcome back.
Okay.
Oh, can you hear us?
Dr. Jaydeep,
I'm
please.
sorry. Yeah.
Great.
We had an electrical blackout, so I had to get in my car and drive up to the top of the hill.
No worries.
I can connect with you in the car on my phone.
All right, great. So let me begin now. We just showed a small video about your life. So let's begin with our chat, which I think everyone is eagerly awaiting. So we will talk about Professor Mathias Fobi or Mal Fobi right from his early days in Cameroon. So let's begin from there, and then we will come back to bariatric surgery, where you truly and firmly belong. So Professor Fobi, tell us about your early life in Cameroon before you moved to the US. What made you decide that you want to pursue a career in medicine?
Well, basically, I was fortunate. I was born in a small village in Cameroon, went to a Catholic school. It was a residential school, boarding school. And I finished and then went to what was called high school. We were in the British system with a O-level and A-level studies. And when I finished that, I started working and then took an exam, which was called a scholarship exam for the United States. And I came to America. I was stimulated to do or encouraged to do medicine by my association with people who were in the medical field. And I was a very good science student, and everybody said, well, you're so good in biology, chemistry, physiology, you're going to be good in medicine. And then I was also good in Latin. And they said, well, now that you can almost talk Latin, then you should go into medicine, and then Greek. We had a very good educational background. We did Latin and Greek, and then the sciences. And that's what stimulated me. I got a scholarship to come to America, and I took that opportunity. However, when I got to America, you couldn't go to a medical school directly because you had to do a 4 years bachelor's degree and then apply for medical school. So I did pharmacy. So my first degree in the United States was in pharmacy. And then luckily after that, I started doing a PhD in pharmacognosy and then got admitted to medical school. And then the rest of the history goes there.
That's right. That's really interesting because Cameroon, as we all know, used to be probably a French colony, and you would have more people going to study in England or France back then, rather than going to the US. Correct me if I'm wrong. And you instead moved to the US and you did your residency at the King Drew Medical College in Los Angeles. And once, as you already mentioned to us in your talk earlier about the Fobi pouch and the banded bypass and how you struck gold while observing or seeing patients of the vertical banded gastroplasties, did you really, think that just keeping that band on the vertical banded gastroplasty and converting it into a gastric bypass was really going to change the face of bariatric surgery one day?
No, I didn't. As a matter of fact, I call it serendipity. That's why I say keep your data when you do surgery. So basically what happened is I was maintaining my data in the bariatric registry. And when you visited me, I always had a fellow doctor, usually a foreign medical graduate, who is trying to get into the residency program, working to collect my data and enter them into the database. So when we looked at the database, we realized that the patients who had the banded procedure and with the gastroenterostomy below it, there were 43 of them to be exact, had better results. And that kind of rang a bell. And then we had been told before that by Dr. Lena that banning the pouch would make a difference. But unfortunately, he was putting the ring in the wrong place. So the question I asked when we had a meeting at the bariatric colloquium in Iowa is, can we then put that ring around the pouch instead of the anastomosis? And there were a couple of us, Dr. Elad Karuzi from Israel, who was there with me, we both agreed that we should do it. And we did it. And since I was entering my data prospectively in the registry, there were many things I could do creatively, because as long as you're doing anything and you're maintaining the data and you consider it investigational, you're allowed to do it. And then my data panned out, and then there were other people who started doing what I did. And there we go. So keeping your data, looking at your data, analyzing your data will show you things. I'll give you an example. When I came to India, Philip, you remember, there were people who told me you cannot do a procedure with malabsorption in Indians because they are vegetarian.
Right, absolutely.
And I says, why don't you do it and put in the data? And now we see we are doing one anastomosis, gastric bypass in India. The people now have the data and they can talk about it. So we have perceptions, and it's unfortunately in medicine we cannot do randomized prospective studies like we can do them in animals. So it has to be part of your clinical work, but the only studies we can do is to maintain the data and review it.
Absolutely. Professor Fobi, if you remember, when I came to visit you in 2011, that's what I found most remarkable is that first your data, the way you had maintained it, and second was your follow-up OPD. You know, when we used to attend your follow-up clinic, and I used to see patients who were 5 years, 7 years, 10 years, 15 years old and post their surgery, and they were still coming and following up with you in your clinic, and you had each and every person's data out there, and it was there for us to see the importance of keeping the data. Another very interesting thing, Dr. Fobi, which I found was that way back in 1983, in one of the newsletters, the bariatric newsletters, which used to be printed back then, you had already mentioned your thoughts that this is not just a weight loss procedure, it is a metabolic surgery. And you had also mentioned about the insulin levels back in 1983. What made you think of that? Again,
well, like you said, it's looking at your data back as I was working closely with my patients. Let me give you a background here, since you're talking to the person Fobi. Being of Indian origin and being who I am right now, I would like to dedicate my talk today to Dr. President Biden and Kamala Harris, who just got elected president and vice president. You have to understand, in America, there's a dual system. It's like what you had in India. There's like a class system. Depending on who you are, the information you deliver is looked at differently. So being a Black person in America, I could not just put out theories and be accepted. I had to put the theory out and document it vigorously. So I came out way back in 1983 and says, I am using this operation to treat diabetes. And everybody looked at me and thought I was a quack. And they would not accept it. It was 13 years later when Walter Forrest in 1985 came out with the same idea, and it got accepted. So I can give you examples of that and other things that happened. If you remember when you came to my center, I said, there is something after the gastric bypass that causes satiation. When food goes into the small bowel, I took that idea to the pharmaceutical companies. I said, the people who have a gastric bypass do produce what I call an enterokinin. We want to know what it is. They did not take me serious. Only to have Dr. Cummings come up with the same idea, and he was taking. I have a ring that was good and effective. But when I took it for FDA approval, I did not have the lobbyists and the money to lobby the appropriate people to get it approved. So I ran out of money in the midst of the whole work. Whereas people can come up with any idea and be telling me whether you have blonde hair, blue eyes, you can get financing. Look like the laparoscopic adjustable band. The studies were very poor. But when you had the correct people putting it forward, they got money to do the work and publicize it. So, but I think Mr. Trump showed you the picture of the United States that most of you did not see. It's a very funny society. It's one of the best. I mean, it's the best of terrible societies. That's all I can tell you. I love it here, but when you're a black man here, you cannot breathe. You got to prove yourself every day. And that's what I tell my friends. And when I'm in India, I say, look, guys, you have the smartest people in India, but you guys have to prove whatever you do to be accepted.
That's right, Professor Fobi.
I hope you got the point.
Yes, absolutely. That was indeed bang on target. And I remember the times when you used to struggle with the reams and reams of files that you had to get your US FDA approval for the Fobi ring. And I was there to witness part of it back during my visit as well. And so one more question to you regarding the band or the ring is that if you remember back then when, during those visits after 2012, when you started visiting India more frequently, there was this discussion that we had about the banded gastric bypass and extrapolating it to the banded sleeve or making it a banded sleeve, or also putting it on the one anastomosis gastric bypass, because till then I think nobody had used the ring for the one anastomosis gastric bypass. What do you think is the scientific rationale, and whether the same Fobi pouch can be scientifically extrapolated to the one anastomosis gastric bypass?
Yes, we have done that. We have at Mohawk, we have 6-year follow-up on the banded sleeve. We have 3 years follow-up on the banded one anastomosis gastric bypass. In the one anastomosis gastric bypass, we had to decrease the biliopancreatic limb because anything 200 and more had increased protein caloric malnutrition. And when you start decreasing the biliopancreatic limb, then you don't have adequate weight loss, particularly in the super obese. So in super obese patients, we started banning the pouch, and we found out that the incidence of protein caloric malnutrition decreases, whereas the weight maintenance increases. And we're keeping that data prospectively in the OC Dendrite registry, which is accessible to anybody who can look at it. And so far, we think that is going to be the way to go in the future. We also found out that the people who have protein malnutrition are mostly patients who have a BMI of less than 45 or less than 40. So you would try to avoid the one anastomosis gastric bypass in patients with BMI between 27 and 40. But if you do it in somebody who has a BMI of 60, 70, they're not going to come down with protein malnutrition. Very rarely.
So you're suggesting...
To answer your question, yes, that...
Sorry, carry on.
I'm suggesting that you can use the ring. I'm suggesting that you can use it in the sleeve and the one anastomosis gastric bypass, but you have to use it selectively. The problem is having a surgeon that bans everything. You shouldn't ban every sleeve. You shouldn't ban every gastric bypass, and you shouldn't ban every one anastomosis gastric bypass. If you have a patient who is super obese, you may want to do a one anastomosis gastric bypass. And then in some cases, you might want to do a sleeve. And then in some cases, you might want to do a gastric bypass. That's why we have an algorithm that we follow at Mohawk, and many people are beginning to adapt that algorithm at this time.
Right.
Sure.
That I think will take away the cloud over putting a band over the sleeve and the one anastomosis gastric bypass for most surgeons who are watching this show today. Also, I wanted to ask you, how do you perceive the evolution of bariatric surgery over the last 6 decades that you have witnessed it to the present times, especially in India? Professor Fobi, are you with us?
Well, we have a big problem with bariatric surgery. The problem is, phone in a car on the street. Can you hear me?
Yeah, we can. Yes, we can.
Okay. Yeah. Doctors are looking for easy procedures rather than effective procedures. I think you should take an effective procedure and make it safe, rather than look for a safe procedure and do a lot of them. And doctors should treat the patients rather than advocate a particular procedure. And that is where the evolution has to go.
Right. Professor Fobi, this is a question which I've always wanted to ask you. What made you come to India and stay at Mohawk and Indore, leaving everything that you have back in the United States and what you built over so many years?
Well, I've officially retired in 2014. So my wife and I traveled the world, and then Dr. Bandari and the family came and asked me to join them at Mohawk. I had the impression I was going to come there and work for about 2 months. And so I came there to work for 2 months. I didn't even bring my wife. And after 2 months, I was planning to go back when they asked me to do more, and then decided to give me a 1-year contract that was extended to 2 years. And then now we're going to 4 years. So it was not, I wasn't planning to move to India. But it was fascinating because when I got to Mohawk, I found 7,000 cases that had been done. They had good data because they had entered their data into the international registry and the SRC registry. So I had data to work with. And when I analyzed the data and showed them what they were producing, they were impressed and therefore decided to keep me. So I really did not plan to come and stay in India, but I'll say, in addition, it was very stimulating because traveling after I retired and I was away from bariatric surgery was not, you know, as a surgeon, you like to be around what you do. And then I had a lot of hospitality from the other doctors in India, you, Raman, Pradeep, you know, all the other people that invited me, Praveen Bhatia, the other Bhatia in Calcutta, or Tomtia, all of you were so nice. And invited me to all the different towns in India. That made it nice. And I found out that the Indian bariatric surgeons were eager to learn. And so I shared my knowledge and it was appreciated. When you are appreciated, that makes you comfortable. So I am back in the States now because of COVID and because I'm getting old. But I still enjoy it because I'm able to work with the doctors in India and internationally and with the Bandera group virtually.
Dr. Fobi, I think the pleasure and the honor was all ours. And we have, as Dr. Raman Goel already mentioned, that we have been really fortunate because after your advent in India in the last 4 years, you've already witnessed the increasing number of publications and data which has come out from the Indian bariatric surgeons. And I think we will probably go only from strength to strength with your guidance. Another question, or rather a small statement from you here, I would like you to, you know, tell all the young surgeons or give your piece of advice for all the young surgeons who have embarked on the path of bariatric surgery in India, especially. What would you like to tell them? How would you like to guide them when it comes to selecting the practice of bariatric surgery, how they grow their practice in bariatric surgery, how to avoid their complications, how to tackle them, or how to, you know, make sure that it is the effective procedure which is made the safest in their practice, as you put it earlier on?
Well, that's a 64 million question. I wish I could give them a simple advice that works. I can only tell you what I did. I was dedicated. I spent time with my patients. I talked to my patients. I read. I looked at what other doctors did. I was not hesitant to ask for help. If you talk to Dr. Mason, I would call him and ask him for help. And that's all I'll tell everybody. Get educated about the procedures, know the complications, and then
Professor Fobi, we just lost you for the last sentence. If you could repeat it.
Okay, I just said you should, the young surgeons should know how to do more than one operation, learn how to do endoscopic surgery or do endoscopy, because it's very important when you can do your own endoscopy. And don't be hesitant to ask for help from a senior surgeon or a more experienced surgeon. And don't be hesitant to refer complicated patients out.
All right.
And don't be a one, take the time and learn. And you'll be for the betterment of our patients.
Thank you. Thank you very much, Professor Fobi. One last question to you.
That's fine. Can you hear
this is not about surgery. This is about your philanthropy and all the work that you've done for people in your country of origin in Cameroon, and also people in America. What drives you to do all this philanthropy? You and your wife, beautiful Mrs. Helen. What drives you to do this? Professor Fobi, are you with us?
I think he has some challenge.
Well, I came from a very poor background. And I have been fortunate to be. I'm sorry about this, but boy, this is a shame. But can you hear me?
Yeah, we can hear you well.
I'm talking from. Okay. I came from a poor background and I'm just paying back.
I think we all must learn this particular aspect as well, being in the situation that we are, especially after being hit by a pandemic, which none of us ever imagined witnessing in our lifetime. So I think that's, again, a take home for all of us here today to learn from Professor Fobi. And I think that's probably most of the questions that we had for you, Professor Fobi. I would like to ask Dr. Kanagwel now to see if we have any questions from the audience for you for today's chat.
Thank you, Dr. Jaydeep. You covered almost the spectrum of Dr. Fobi's life. I have one question to Professor Fobi. Fobi, sir, are you with us?
Yeah, I'm with you.
Yes. Dr. Fobi, there have been one questions like Dr. Jaydeep, and you were sharing about the difficulties of your early part of your career, trying to establish and standardize the bariatric operations. I'm sure you'd have had your share of complications and difficulties and challenges. Like say, if you can tell us the nutshell, if you land up in a disaster, if you land up in a trouble after bariatric surgery, how a young surgeon should face first the family, next the problem as such. Can you briefly tell us?
Yeah, that is what. Okay, it is very important that the surgeon bond with the patients. Bariatric surgery is different from other surgeries. When you do a cholecystectomy, you take out the gallbladder and you never have to see the patient again. When you do a bariatric operation, you are married to that patient for the life of your patient. So it is nice to know the patient and get to know the family of the patient. Because when you have an untoward reaction or outcome, you should be able to communicate with your patients. I had a few of those, and they were trying, because the patients became like my friends. And when I had to lose a patient, I suffered for it for a long time. But again, that was me. But I think that allowed me to treat my patients with empathy. My patients were not just an object to operate on. They were like my brothers and sisters that I was taking care of and hoping that they will get a better life after they finish the operation. And therefore, the one-to-one contact with the patient is very important. Number two, don't hesitate to ask for assistance when you have a complication. One of the things that made me do well was that I established a multidisciplinary system. Dr. Pelip and Dr. Ramengo would tell you, I had a group of 13 people that took care of my patients, the gastroenterologist, radiologist, cardiologist, pulmonary specialist, endocrinologist, psychologist. When you have all those people, somebody is going to be there to help you when you have a problem. And you cannot miss much because somebody will pick it up. So that's all I can tell you. A multidisciplinary team is an important part of bariatric surgery. And no surgeon should go out there and do bariatric surgery alone. You should at least have an...
Thank you, Dr.
associate who
Fobi.
can do the procedure. Have an anesthesiologist that does the... Go ahead.
Thank you, Dr. Fobi.
I'm sorry about the poor communication.
I think I understand, and thank you for getting into your car and allowing the program to continue. IAGES places its thanks to you for sharing your expertise and time, your wisdom, and the most important advices to the benefit of the youngsters. And now I request our president to give his closing comments before we move on to the vote of thanks. Dr. Raman Goel, please.
Thank you.
Dr. Fobi has covered most of the issues that we wanted to highlight, and they are not bariatric specific. They apply for all the surgical aspects. And this is why this program is so important, that we bring the legends and we learn from them. You know, surgical technique one can learn from their teachers in their medical colleges. But learning, getting the wisdom and having these pearls of wisdom are so important from different people. So thank you, Dr. Fobi, for joining. I request Dr. Ishwar Murthy, who is Honorary Secretary of IAGES, to propose a vote of thanks. Ishwar?
Thank you.
You will have to unmute, yeah.
Thank you, President Kanakavel. I think it has been a cracker of a day. Hoping that the Diwali is on the way. I think this is a perfect way to welcome our Diwali. And Jaideep, you've done a wonderful thing. An energetic EC member from the West Zone. Like a typical Western movie, we are firing all guns, trying to get the best of the best in the bariatric world, who's having so much of research, who is a proponent for banded bariatric surgery, Professor Fobi sir. It's really a treat to watch. And I thank all the viewers who are passionately listening and supporting our prime time. And I think it is yet another wonderful show. Before we close in with the Diwali, I think we have at least 3 treats from our president. I would say the 3 laddu news for all of you to have a league. Number 1, if you're a PG, please try to see whether you have done the submitted nice thesis this year. Then you can apply for the best thesis award. There are 5 such awards, each worth 1 lakh rupees waiting for you as a gift, as a Diwali from IAGES. If you're an IAGES member, yes, and you have done some research work, there it is. As a best researcher, you can get one of the 5 best awards, each for 1 lakh. And if you are already contemplating or already taking our online fellowship courses, either endoscopic, laparoscopy, yes, now you can think about taking the assessment and also the convocation virtually. So there is plenty to offer in IAGES. Keep watching, keep docking in IAGES.in. And until that time, I think time for our cracker of a show for all of you. Bye-bye now.
Thank you again. Thank you, Dr. Ishwar Murthy, sir. On behalf of the IAGES, I formally thank Professor Fobi, Dr. Jaideep for making this evening possible. Thank you, President Dr. Raman Goel, sir, and Ishwar Murthy, sir, for allowing me to do this program. And I also put on our prayers to Professor Samiran Nundy and for his early recovery. So I'm sure we will be having celebrations as Dr. Ishwar Murthy, sir, is having very soon in the coming week. And that is the spirit of India, and that is the spirit of IAGES, brotherhood and familyhood. So
thank you, Fobi. Have a nice Diwali, Fobi, sir.
Thank you,
So,
thank you.
Thank you.
Have a great day and a great weekend.
Thank you.
IAGES wishes a happy Diwali to all the members and all the viewers. And we look forward for yet another important edition of the IAGES Prime. Thank you, one and all. Wish you a good night. Bye-bye.
Thanks. Bye-bye. Have a good evening.
Bye.